Okay, it's just past 9 o'clock, so we're going to get started. Um, Hello, everyone. My name is Julia Henderson. I'm an investigator with UBC's Edwin S.H. Leong Centre for Healthy Aging, and I'm co-chair of its of community engagement and intersection for the center. I'm also the chair of the North American Network in Aging Studies. And so on behalf of both organizations, I would like to welcome you and say how excited we are to sponsor this book talk today with Margaret Morganroth Gullette. To begin, I'd like to acknowledge that the University of British Columbia's Edwin S.H. Leong Centre for Healthy Aging is located on UBC's Point Grey campus in what settlers refer to as Vancouver, British Columbia, Canada. These lands are the traditional, ancestral, unceded, and stolen territories of the Hunkaminam-speaking Musqueam peoples, and we acknowledge that we're here as uninvited guests on this territory, or most of us are. I'm deeply grateful to the traditional caretakers of these lands and waterways who have cared for them across deep time, and I'm honored to live, work, and learn here. In addition, as this is a virtual seminar, we have people joining us from many locations across the country and around the world, including Margaret, who is in Europe. So from coast to coast to coast and beyond, I acknowledge the traditional ancestral territories of all the Inuit, Métis, and Indigenous First Nations peoples and other Indigenous peoples, and thank them with gratitude for their stewardship of these lands. So just one note for everyone, we are recording the talk today and it will be archived afterwards, both on the Edwin S.H. Leong Centre for Healthy Aging website and the NANAS website. And now I'm going to turn things over to our moderator today, Dr. Benjamin Gillespie. Ben's an assistant professor of theater at Santa Clara University in California and a member at large of NANAS Governing Council. To you, Ben.
All right. Thank you very much. Thank you very much, Julia. Is it working? Can you see me? Yes? Okay. All right. So I have the pleasure of introducing our speaker today, Margaret Morganroth Gullette, and I'll give a brief bio and then I'll turn things over to her. So Margaret Morganroth Gullette is an internationally known cultural critic, an essayist, anti-ageist activist, and prize-winning writer of nonfiction. Her writings are foundational in critical age studies, a cross-disciplinary field which she named in 1993. Her latest book, American Eldercide: How It Happened, How to Prevent It, published in 2024 and nominated for a Pulitzer, has won a Mass Cultural Council 2025 grant in literature. Ending Ageism, or How Not to Shoot Old People, published in 2017, won the Modern Language Association Prize for Independent Scholars and the American Psychological Association's Florence Denmark Award for contributions to women and aging. Aged by Culture, which I know many of us know well, also nominated for a Pulitzer, was chosen as a notable book of the year by the Christian Science Monitor. Declining to Decline, published in 1998, won the Emily Toth Award for the Best Feminist Book on American Popular Culture, and her essays are often cited as notable in Best American Essays. So welcome, Margaret, and we're so happy to have you here for this event. I will turn it over to you.
Well, I am so happy to be here. Many thanks to NANAS, many thanks to the Leong Centre for Healthy Aging. And I actually know the former poet laureate of Canada, who is a First Nations person, Louise Half. If you don't know her work, let me just recommend it right here. I'm very glad today that you are giving me a chance to talk to people who already care about older adults and people with disabilities, scholars and activists and colleagues and students. In age studies, by now, we have passed what I would call the vanguard period of theory, and when we had to declare that we should study old age and ageism. And now many of you and many of us are doing the work. Across the globe, we share the thrill of a relatively new movement a new intersection, wide open to new ideas. Being here with you today frees me to talk about American Eldercide, my latest book, in new ways. American Eldercide is the most deliberately organized and the most carefully, intensely written of my books. It had to be. As a writer, I confronted challenging questions. Will anyone want to read this book? Can they endure the evils that I describe? The use of the word evil. How do I want them to feel? How can I get them to feel empathy without disgust? What will they need to know? So what I'm saying is the research questions were sort of behind me. Well, not entirely. They never are. You're still adding endnotes and fixing them up until the very last minute, writing the index and so forth. But I am going to be talking about the writing. I'm going to ask Ben to provide the first slide. But I do want to encourage people to ask questions because this is sort of new for NANAS. I think often we think more about asking for content. Well, the first slide that has text, then? Okay. So I've said this was the first issue and how to structure it. How can I create empathy and why do I need to do it right away? So these are the first sentences of the book. I'm not going to read every slide because people read faster than I, and because it's boring to hear the same words that you are seeing. That's the PowerPoint issue usually, but I guarantee you that the grieving are thinking about this every single day. So the three parts of the book are inside, instead, and ahead. And inside means getting close to the residents who were enduring the COVID incursions in their nursing homes. And with them were a lot of people, about a third, were just people who by accident were in the nursing homes. They were there because they'd broken a leg or something. They were on Medicare and not on Medicaid. So these first sentences tell readers that these dead were mournable. They were loved. So I'm going to ask you whether you think this was necessary. And there's a sort of lag as you're typing. So Ben is going to tell me if there is anybody who has something interesting to say about whether creating empathy was necessary. The disproportionate deaths of so many residents of nursing facilities in the COVID epidemic of 2020 should have been shocking. But no one seemed surprised, wary, alert to the avoidable evil causes. The most insistent question of the book was, why no outrage? One obvious answer was that there were too many deaths. 1,400,000 residents had constitute only 0.42% of all US inhabitants, a number that was small enough and localized enough, we knew where they were, for them to have been properly protected. But they died of COVID 26 times as often as people living in the community, 26 times as often. The coronavirus rampaging outside the walls made them seem more like soldiers in bunkers waiting for incoming artillery. And they were the first to die. So, however, if I had stopped there with the data, which I do give pretty early, there would have been just mere data. There would have been no story, no question, no evil, no one to blame, nothing to explain, and nothing to change. But as social critics, as social activists, you want to know why things like this happen to people when they shouldn't. Why were so many dying? There were too many, and they were not just excess deaths, which are expected in a pandemic, these COVID deaths. And certainly we expect deaths to go on in nursing homes. So the COVID deaths are excess deaths. They're not people dying of the usual heart attacks or strokes or whatever. These are extra deaths. Now, extra deaths requires a little explanation. The ones that are preventable, that should never happen. Amartya Sen, the Nobel Prize winner, had discovered extra women's deaths, and he called them extra, and they were too many women, too many girls dying as they were born as neonates, too many girls dying before the age of 5, too many women dying at the age of 20, extra deaths. So the first answer to all of this that came to me was that as a society, we did not have enough empathy for the people who had been isolated from the rest of us in the institutions we call nursing homes. But what impeded empathy? Well, the press kept pumping out the mortality data weekly, and it was obvious that the residents were dying in clusters. And what this did was it confirmed a dehumanizing stereotype of them as fragile. And for such needy, dependent old people, dying was the next normal state. So the question was, how did people feel about it? And what I'm arguing in the book, I'm not giving all the reasons here, is that they felt a spectrum of emotions. But aversion also exists at the intolerant end of a range of emotions toward lesser others. Aversion was evoked or it was heightened by fears of being old, of being them in the new COVID era. And being old suddenly had gotten much younger. People who were 55 and 60 were being talked about in the media as if they were old. That was frightening or it was irritating to some people, but it was frightening to other people. I want to say here something that I do say early in the book. In fact, they didn't all die. Of the 1,400,000, about 1 million or more survived. That means, and many of them had COVID, they got COVID and they recovered. So we're talking about a very resilient population of which 85 to 90% survived COVID. I think the new keyword for them, though, was futility. Though there was no hope of saving them. This was the common discourse of futility. It was an assumption that you couldn't save them. So by that time in my analysis, thinking about why there was so little empathy, the problem for writing my book was that readers might not have empathy for the residents either. The COVID epidemic was declared over in 2021, really way too early. But while I was, and in fact, I was nowhere near finished with my research. So it was possible that these disproportionate deaths had become what we call colloquially history, meaning a history that people did not want to be reminded of. How could my narrative be made current then? How could the people I focused on first be made appealing? So that's a slightly different issue. How do you make them appealing? So I went inside to create what I called their social portrait. May I have the third slide, whoever is able? Okay, so there was a certain amount of data when I did this, the paragraph, it's the second paragraph I want to bring your attention to, these noble artworks, like my father in his 60s, whose profile was like Giovanni Bellini's Doge Loredon. Or one of them looked like Käthe Kollwitz's later self-portraits with a chiseled nose and fierce determination. I could imagine a dapper mustachioed man straight out of Gordon Parks' portfolio, a man who is the spit of Lucian Freud in later life, looking stern. I should say that none of these people turns up on the cover of the book, but the cover of the book, I hope you get to look at it. It has 99 portraits of people who are over, well, let's say they're over 65, but many of them are over 80. And the only thing I said to the designers was make sure that about 70–75% of them are women, because that's who was in the nursing homes, and make sure that a certain percentage are Latino and a certain percentage are Black. And let's have some really old people if we can, because there are many centenarians. That's a whole interesting question. There are many centenarians in nursing homes. They're not usually, many people die and they die prematurely, but many also live there for 10, 15, 20 years. Okay, so what you see in this slide is a certain amount of sociology, but a lot more of what you could call, whether you like it or not, creative nonfiction prose. And I did this with many touches. This is just a small sample. So the question is, does this sort of thing humanize the residents or not? And do you believe that one should be able to do this? The tones and the topics veer across disciplines. Even you can see that here. So there's art appreciation, and then there's my father, family affection, and then there's exposing healthcare deficiencies that are not their fault. That is to say, talking about those younger people who can have ALS or Parkinson's or multiple sclerosis or Alzheimer's. And these do strike young. And that's why you see many people who are otherwise healthy who have lived in a nursing home a long time. Slide 4, please. So this is another sort of humanizing them. I just want to say, in Massachusetts, the minimum amount of space a resident gets is 90 square feet. That's 9 by 10. I don't know, just look around you and see what it would be like for you to live in a bed with a chair beside it in a space that was 9 by 10. Now, some of them may be bigger, but that's the minimum, that's the rule, that's the way Massachusetts wants it. So there are photos of family members, and the point is every object enfolds a precious fragment of the occupant's personality and history. So I let you imagine that, a small flag, a crucifix, tortoiseshell bifocals, a Raggedy Ann, an award with a name, and then this paragraph. In the top drawer of a small bedside chest, securely wrapped, his Swiss Army knife, the expensive one, with multiple functions, the last of his tools to go. Inside a grandmother's woven bamboo sewing basket, small snipping scissors shaped like a crane. In a bottom drawer, a packet of the thinnest airmail letters from Korea via Army Post Office 246, with the one on top marked return to sender. So that's all early in the book. So in an endnote, I do admit to writing fiction in one place. It's a scene based on an article in the Gerontologist about an incident where aides neglect and treat as an object a resident who cannot or does not speak, a man. The setting, only the setting is fictitious. A woman is describing this rudeness to her sister who is visiting her. They dicked around with him, she says. And the sister excoriates Congress's role in understaffing. Congress forgets to bring in the bedpan. Of course, I quote the residents, as many as I could find to quote. Most reporters never tried to find them to interview. You can probably guess why. You anti-ableists, you can figure this out. But chapter 6 tells you, goes through all the reasons why they may have failed and then gets to the real point. The next slide, please. I like cartoons. I've written about cartoons in one of our many collections of relevant books about literature and the arts. And you can see why I might like this one. We had one job. What went wrong? So here I'm going to talk a little bit about eldercide, the term eldercide. How can you call it eldercide? I anticipated people saying, if the deaths were natural. Well, the danger, as we know, is that aging is considered a purely biological process rather than one where we are aged by culture in particular societies at particular historical moments with these societies' own biases and with particular effects on the victims. And here he's, I think, made a very nice drawing, but he's calling this woman new US nursing homes, and it's the protections that disappeared. So in part two, which is called instead of the protections, what happened? Who's the dragon there? The residents should have been protected by the government, most weren't. The Trump administration abandoned them. It stopped inspections. It stopped inspections with the rationale that inspectors couldn't enter the contaminated buildings without personal protective equipment. But it made no attempt to provide state facilities with personal protective equipment. How they got away with that without the media noticing was my discovery, made through close reading of government documents. I like to, I.F. Stone was one of my heroes, and he said to us all, read the government documents. And it actually is a help if you've been a literature major that you know how to do close reading, even of government documents. It's a different, slightly different kind of close reading. But you're looking at everything. You're looking at the metaphors too. Okay. This is the revelation of chapter 2, what did wrong. But the state governments did know better. In Massachusetts, they sent personal protective equipment to the hospitals at a time when the people who were dying most already, those were in the nursing homes, should have been kept safe in their rooms. Out of the 15, and some of them were kept safe. This is a bit of data, but I think it's an important bit of data. Out of the 15,400 facilities in the country, 1,950 had no deaths in 2020. No deaths among residents or aides or staff. So some were kept safe. And I do say how one of them did it, and probably the same methods were used for the other 1,949. Any comments, Ben? Should I be?
We don't have any comments at the moment, Margaret, but just a reminder to participants, if you do want to add a comment or a question, please do so in the chat and I will relay it.
Okay. The next slide. Well, so the second part instead had to demonstrate the evils. And so I do this in many different ways, but I'm not going to tell you about all of them. But this one was by the hospitals and the doctors and the people who call themselves ethicists. This happened very early. It happened almost immediately, as a matter of fact. And I think it was an attempt to keep older people and residents of nursing homes out of the hospital emergency rooms and ICUs. But they produced the guidelines for ICU ventilators that excluded people by age in groupings. So, okay, the first group, the priority group, was the younger ones, and then over 40, no, over 60, no. If that is to say, if there was scarcity in the ventilators, if you didn't have enough ventilators in your ICU, at that time, ventilators were thought to be the state-of-the-art response to COVID, and many people did need them, and many people did get them, and many people did survive even for very long times. There's a whole section on a guy called Lucky Larry. He was 64, not 65. He got admitted early in New York City, and they just kept him on the ventilator, and he survived. Um, and the scorekeepers, it's all done numerically. We're asked to estimate an individual's remaining number of years of life. Well, that's not really fair. In a society that has lacked Medicare for all, for people younger than 65, for the entire 60 years of Medicare's existence, a society that is burdened by racism, by market-driven capitalism, and small government ideology, injustice is built into any crisis standard of care that prioritizes highest long-term survival. So crisis standard of care is a term of art. The government, the Trump Azar, who was running Health and Human Services, had created called it an emergency. It was an emergency, but you can do crisis standards of care, for example, in the hospitals, and you can produce guidelines like this. This was legal. Now, did it happen, or we don't know. But for me, it looked like pure ageism could be the killer. Pure ageism, not the other stuff, not ableism and whatnot. I read the guidelines in shock because they meant me. I mean, and I'm way over 65. But in writing about this, I just want to say I kept myself out of it most of the time. I turned to the cool but forceful idioms of social justice, economics, and public policy. And so that's what you see here. You see that cool language, market-driven capitalism, small government ideology. You can talk about scarcity as a Republican priority. And you can link all of these to injustice. Now, of course, it seems no accident that hospital guidelines prioritized younger people as the neediest and worthiest patients, at the same time that the discourse of youth ascendancy was prizing their vitality. So I don't know if you remember this, but the young were supposed to be exempt. And Trump was the person who sort of promulgated this wrong news. It was incorrect. He had known since January 25, 2020, this is before we even knew that there was a COVID global emergency, that this fierce new contagion was dangerous to all ages. But publicly, he lied. He said, take your hats off to the young because they have a hell of an immune system. That's on page 60. If you want to see that. Slide 7, please. And then what happened is when the Centers for Medicare and Medicaid abandoned their own inspectional system, they gave everything over to the owners of the facilities. So who owned your facility was likely to decide whether you lived or died. Since we know that 1,950 facilities were the life-giving ones, we know that there was a lot of people doing wrong things. And this was what happened when protective gear was finally procurable and billions of federal dollars had been sent to the owners, the eligible owners. Well, they didn't do much with it. That's the fact. It's a deadly fact. Those facilities that had reported severe shortages in May, they had infection outbreaks, they had low ratings, and they were admitting Medicaid patients. They were admitting more patients when they should not have been. Well, they did not meaningfully improve these conditions by July. And when the inspectors finally came in, they just found horrors. Some people had bed sores neglected so long, they sustained gruesome injuries. All these facilities should have been adding staff, but they had cut staff. And this is from chapter 3, which I think for cultural critics may be one of the most interesting chapters. It's how Americans learn to accept that the old would die. And the old there, we're not supposed to use that term, but I'm using it the way I think it became a key word in US culture, and actually all over the world. The old became this homogeneous category. We know not to do that, but in the media, it happened all the time. Next slide, please. So I'm still into explaining the lack of empathy, and there were explanations at the time, and of course many later. But this is a concept that I think is very useful. We know in public health, we know social determinants of health. This is social determinants of death. I think they move us past biomedical explanations of futility to the search for overlapping discriminations on the part of those with most power. And there's a journal for medical directors, and they summarize the lacks, and that's their conclusion, which is our conclusion. But there's a lot more about what renders that patient and resident population and workforce invisible. And I imagine many of you know that. At bottom, as you will have guessed, you listening, the social trouble was a deep and often unconscious prejudice I call compound ageism. Compound ageism is a term we ought to use to describe the harms inflicted on the least of these. That is to say, nursing home residents, long-term care residents, older adults in prisons, the unhoused, living under bridges or in tents, people with disabilities in later life. What they have in common is indigence. So ageism, sexism, racism, ableism, classism, all components of compound ageism. Now, I see a comment. I guess I should have my chat on. I can look at the chat. Okay, I see, yeah, prevalent amongst older adults themselves, and that can be very damaging. It certainly can. I hope I'll get to that later. Please, somebody remind me. But at the moment, I'm talking about ageism in society because I'm talking about empathy. Empathy in Congress, empathy in nursing home ownership, the lack of it. I think it was Cory Booker in that amazing 25-hour talk of his who said, we lack empathy in the United States. And I'm talking also about a system rather than individuals. So I want to talk about evil. The question of evil. When do we dare use the word evil about a system or a society? I am sure that I had never done so in an earlier book. In fact, in this book, I find I used it 18 times. I don't know whether that's enough, too much. Evildoers comes up. I'm going to be very frank here. I didn't know how to talk about evil. I didn't know how to write about this kind of evil, which is abandonment at a very, from the media and from these owners and from the government and from the states. It overwhelmed me. And how was I going to write about it? So what I did over time, I reread or read Hannah Arendt, George Orwell, and I read people who had confronted the greatest evils of the 20th century and had been able to write about them. And Vasily Grossman, I have to mention Vasily Grossman's great 20th century novel, Life and Fate, which is set in Stalingrad in 1942. And it's about the gulags in the Soviet Union and about the concentration and death camps in Germany, and it's about how people, mostly it's about Jews resisting um, going to their deaths. Here is an explanation of evil in the next slide. There's a theory. This seemed so impressive to me. It made things clearer that were in the book, but that I didn't know how to talk about. Okay, it's James Baldwin. He called it morbid fullness of pride. And he was just explaining racism. He was explaining the emotions that made white Americans dangerous to Black Americans in the Jim Crow era. Um, Baldwin had an intuition of how racists felt after they acted on ideas that he, as a former boy preacher, but not they, could see as wickedness. Now, you know, James Baldwin started off in a preaching family, and he has readily accessible to him language of sin and wickedness. But the important idea for me is pride here, because what we got talking about the residents dying, or the risks they were undergoing, was casual self-righteousness of published utterances. I mean, people said, well, you know, maybe this is culling the herd. So Baldwin's kind of pride justifies blindness and can be applied to any archive of ageism. People don't speak confidently in public without proudly aligning with what they consider the good side. But you often have financial stimulus to decide what the good side is. Or you have something that you could call an emotional desire to connect. So there were all these writers and doctors who were arguing that the guidelines were correct because younger people needed fair innings. They should get fair innings means, you know, all the innings of the life course. The younger people really needed them more than older people. And when you said this, it seems to me that you were sidling closer to the gloriously vibrant young. I don't know if you remember that in March of that year, the colleges let students out, and many of them went south and went on the beaches. And so we saw them being gloriously vibrant and young, and drinking beer. At the same time, of course, that the older people were not getting their PPE. Okay, and Governor DeSantis talked about Florida as God's antechamber. He said, Florida is ground zero for the nursing home. I mean, we are God's antechamber. So again, there's that idea that, of course, they're just waiting to die in nursing homes. I have to say, of all the people, a million people or more survived, got COVID, but survived, these resilient people. So they woke up after COVID, and now, you know, you could go interview them. They're there, and they surely have good stories to tell that didn't get into the papers at the time. And the last, okay, I left out one, but it requires too much explanation about what was wrong with the Centers for Medicare and Medicaid. I've already, but find out who Seema Verma is. If you're going to read this book, start around page 64, 65, 66, 67, and find out Seema Verma. She was Trump's head of Centers for Medicare and Medicaid. I mean, you know, sometimes you just can't believe whom people think is the good side. For her, the good side were the owners of the nursing homes. Okay, and I also talk about eugenics and how eugenics has sort of bedeviled American social theory for a very long time. Okay, I'm going to talk about, let me see, is there another slide here or it's just me? Oh, yeah. Okay, I had to decide at every moment whether to reveal my own reactions, and then how strongly and where and in what context. So this passage comes rather late in the book, slide 10. Or is that slide 10?
Yes, this is slide 10, Margaret. Do you want this?
Oh, okay. I'm
Or...
sorry.
Okay.
Sorry. I guess I lost my place. So, I mean, here I did actually use rather heightened language, frightening, twisted ways in which common othering functions, um, just to conclude how compound ageism could operate in domain after domain in year one of the new era. Um, So, I mean, I could use findings as coverage for emotion without getting, I hope, overwrought. And also, I didn't use the I very much. I didn't tell much about me. And when I did, initially, it was always in a parenthesis because I felt, well, this is not my story. I mean, I was safe. I was in my home. Anyway, next slide. Yeah, well, how to prevent it? We need to reform the Centers for Medicare and Medicaid. We need Congress to take on its responsibilities. And this is the socio-political question. You have to prevent public agencies and politicians, and these are the people responsible for public health and public policy, from being waylaid by rich, greedy, ideological donors who are careless of human lives. And there are many good people in Congress, many good people, many senators who have tried to improve the nursing home system for decades. And they simply have been unable to do the most important thing, um, um, which is to understaffing, to control understaffing. Okay, there's one more slide, and then I really should, oh, I think I won't read this. Biden managed to do an executive order in which he actually did something that Congress had never done, and Congress still hasn't done, and that is to set a minimum staffing mandate. And it's only 3.48 hours. This is too low. All the reformers think it should be over 4 hours. But in almost every state, it would have meant hiring more aides and nurses and improving the care that residents receive daily. It was a preventive reform. Okay, I'll just read the last words of the book, and then the undaunted reformers are dug in for the long term to pursue age justice. Ever growing in numbers, we fight on, reminding us tirelessly that older people have an equal right to live. We find ourselves churning toward a vast, slow, thorough, blessed transformation of human consciousness. The great wave of true caring moves on. Well, thank you. Thank you for being here. And I'm hoping to see more questions.
Thank you so much, Margaret. That was wonderful to hear you talk about your incredible book. Um, we do have the question that came up earlier in the chat. I'm not sure if you want to address that question now. I do have several questions myself, but we did have the question, can you share your thoughts on ageism that's quite prevalent amongst older adults and also, damaging to them? Obviously, that's a much broader question, but maybe that could lead into, what now after this book? I mean, what's happening, currently? You sort of captured a moment in this book or a span of time, but where do you think we're going, or what's happening now in your view?
Yeah. Let me come to both of those, but let me just respond to Edie Cheers talking about racism and sexism. 70% of the people in nursing homes in 2019, which was my sort of initial data point, were women. So Edie's absolutely right that when the government, Trump certainly was ageist and sexist and racist, and we know that he still is. So the only other thing I want to say about race is that most of the people in nursing homes were white. And so when the American government abandoned people in nursing homes, they were abandoning white people too. We mustn't forget that, because classism, which in fact I think I did not mention as often as I should have in this talk, classism, all those people who are indigent, the ones who wind up on Medicaid, this two-tier system, Medicare we have, people who are in the middle class. Medicaid is you have to sort of like lose all your money in order to get into a nursing home. I think ageism among older people, I think, is relevant to my book in this way. Of course, it's personally debilitating to think that because you are old, you are ugly, uninteresting, and so forth. But the main thing, I think, as an activist and a social philosopher, I think the main thing is that it prevents us from fighting for ourselves. In other words, how can you get this collective of older people? I mean, we grow old, more and more of us are old, the boomers are aging. How can we become a force in society? I'll just say, this brings together the last two questions. Black Lives Matter happened that spring in 2020. Where was Old Lives Matter? There was no movement of Old Lives Matter. I mean, I was on the Black Lives Matter. I was out on the sidewalk. I had my signs. I had my sign in my house. I was walking with church members, all of us with masks, of course. I mean, I joined that movement. But as I did that, I noticed that there was no Old Lives Matter. And I have a T-shirt, which I should be wearing today, that says Old Lives Matter. I mean, I think anything we can do to, work against self-inflicted ageism, we should do for both emotional, psychological reasons, but also because we need to be able to think of ourselves as an endearing collective that is worth the fight. I mean, and that brings me now to the fact that any of us could be working in various ways in the resistance against Trump. The resistance against Trump is going on many different levels. But when I go out, I do a protest when I'm in the States. I do a protest almost every week. And we have one coming up on the 18th. And I'm going to be back in the States. And I am going to be out there. And, I am going to be saying, I'm going to have a sign. The sign I usually carry is Make America Kind Again. That seems to be a sign everybody likes. But I think I'm going to have an Old Lives Matter, protect Medicaid. I mean, what we're about to lose is tremendously important for all. I mean, kids get Medicaid too. But Medicaid, cutting Medicaid is going to mean that nothing changes in the States in terms of the nursing homes. And I think that we have to be working in each of our states on getting our legislators. There's nothing to hope for until 2026. If we can change the House of Representatives, we can probably stop these Medicaid cuts, and that would be a good thing. So that's part of the resistance. Now, I see Corinne asking about ableism, and of course it intersects with ageism, and compound ageism starts with ageism and ableism, and then goes to sexism, racism, classism, and dementism, which I haven't had time to talk about, but one of our NANAS talks coming up is going to be about dementia. And I'm sure that they will use the word dementism because it's very powerful. I mean, one of the reasons that people dismiss, don't like to think about nursing homes, residents in nursing homes. I hope that, the first part of my book and the cover changes that a little bit. Think about them. They're your neighbors. They're us. Is because they're somewhat, about half of them are disabled, or they're cognitively impaired. I mean, we do know that about them, but that's not the last word to know about them. So I think there's a lot of work to be done. Well, could I say more about how the history of eugenic thinking got recycled and redefined through Eldercide? Yeah, I think if you're very youth oriented in this culture, and very health oriented, and very fitness oriented, then you are liable to find eugenics thinking just teasingly interesting, right? Because eugenics wants to have an American population, or any population, a German population. I mean, Hitler is, of course, the best example, but we want to look at the American examples. We want to look at women who had their tubes tied so that they wouldn't be able to have children. That went on in the early part of the century. A lot of very intelligent people thought that some ways of culling the population of the mentally disabled, mainly, and make America fit again. That's, I think we still see quite a lot of that thinking. And the people who said, well, why not let old people, be cold? We could just, stop trying to protect them, because after all, if they die, sort of, so what? I mean, there was a group of about 400, they weren't really academics, but there were some academics among them, who was called the Great Barrington Declaration. And it looked like it was protective. I mean, there are always rhetorical ways to make this look like not what it really is. But I think that there was, but I think the thesis is doomed to die. I think that's the main connection to Eldercide, that they were doomed to die anyway, because there they were in these institutions far away from us. I actually had been in a nursing home, but I gave a talk to social workers, and I asked how many had ever been in a nursing home. Well, it was really remarkably few. For one thing, I mean, social workers, you have to pay for them in the nursing home. And if you're cutting staffing, that's one of the places you're going to cut. Then you're going to cut aides as well. So I just think this concatenation of compound ageism was devastating to, and still is. I mean, we'll see. I have seen a lot of older adults. Maybe I want to end on a slightly more upbeat note. I see a lot of older adults in these protests, and they're marching and they're carrying signs, and a lot of them are signs about, encouraging migrants, enough with the fear. I've seen that in Spanish. Basta con el miedo. That's great. I think we need, though, as I've said before, but it's a good place for us to move out into social activism, is to carry these Medicaid signs. And I think, Medicare may also be undermined in some ways. We don't, it's hard to read this language and not figure out that The reformers are very worried, and they know whereof they speak.
Thank you so much, Margaret. I think we have time for maybe one more question. I don't see additional one in the chat, but I want you talked a lot about keeping the personal out of this book for you, and that intrigued me. And I was wondering, as you're writing it, obviously it being a very present and difficult subject and one connected to yourself, was the material overwhelming at points and emotionally, difficult to put together this book?
Yeah, yeah, absolutely. Um, I mean, I think it's very hard. I mean, I've lived a long time. I've lived through a lot of periods of American history. I lived through the 1950s. I was a very young person, but the McCarthy era, now it's the Trump era, Americans' wars and whatnot. But there's something about those were foreign wars. We weren't abandoning our own people, abandoning the residents in the nursing homes. And when you get to the last chapter, I do come in again, a little bit. I had one of the people who helped raise me, a friend of my mother's, was in a nursing home towards the end of her life, and I visited her there. So I finally do say, I visited a nursing home, and it was way before COVID. And I knew this. I called her Aunt Vera. I knew. I guess I was just thinking it could be me. I, I couldn't get my mind around the fact that the government would do this. I mean, now we know that that it's all cruelty. It's cruelty up and down the line. It's cruelty to people with disabilities. I mean, all of that, everything that they're doing is to harm the most vulnerable among us. So yes, to discover this, and this is Trump one I'm talking about. Trump one he had barriers. He had people around him who were saying, "You can't do this." I mean, I think I'm better prepared in some ways for Trump too by having confronted what I have called evil, and um, I just think not everybody is getting the same information that I get about public health and about the attacks on disabilities. If I can just take, oops, one more minute. I work with the Dignity Alliance Massachusetts. It's a coalition of people who advocate for older adults and people with disabilities, and we try to get them out of nursing homes. It's not, we don't think that we can make nursing homes better necessarily, not the way we're going. We failed for 60 odd years, 75 years. We think the best thing is to keep people at home and to keep them in the community where we can see them and interact with them and not think of people who are disabled or cognitively impaired as other. There they are. They're walking around in our neighborhood, even with their aids, with their walkers, in their wheelchairs, on their cycles, those tricycles that some people have. We just need to get back. We need to get them back with us. And so that's the main things. To end othering, you want to be with.
Well, thank you so much, Margaret, for your resistance, for your activism, for your work, and also for doing this talk today. I want to also thank the North American Network in Aging Studies and also the Center for Healthy Aging at UBC for hosting this talk. NANAS does have a few more talks coming up. We do have a talk on November 5th. And we do encourage you to visit our website, and in the chat, you can also click on the link for that upcoming talk. So thank you everyone for attending today. And again, thanks Margaret so much. We appreciate your time and speaking about this wonderful book.
Well, thank you for coming. Thank you, Ben and Julia. Thank you to NANAS all together. And if you have more questions, write to me. It's easy to find me. I have a website now. It has a contact page. I'd love to hear from people particularly from people who want to change their writing a little bit.
Well, thank you so much. And again, thanks to everyone for joining us today.